Okay, so the topic of my presentation is anticipated is the role of LH in ovarian stimulation for IVF. Um, and basically, I think as Professor McGraby indicated, I think that in order to better apply our pharmaceutical tools, you have to understand physiology. And in order to understand the physiology of LH, first of all, you have to be aware of something that I'm sure all of you know, that the receptor for LHCG is a single receptor that binds to both LH and HCG. It is always expressed in TICA cells, and it has enhanced expression in granulosa cells in the mid to late follicular phase. And basically that is what makes the follicle capable of ovulating, because it's only then that the follicle can respond to the mid-cycle LH surge. And also it's highly expressed by the corpus luteum, and that's how, pulsatile LH can support the corpus luteum by creating pulsatile progesterone secretion in physiology, but also how you support an IVF cycle luteal phase by giving LH or giving HCG when you're not concerned about hyperstimulation. It is also expressed by extra-ovarian structures such as myometrium and uterine blood vessels, but of course tonight we don't have the time to go into that. And so I will concentrate mostly on how we're using LH activity. First of all, how do you get LH activity? There are several preparations that are available, I think all over most countries in the world, and I'm sure that they are available also in Egypt. You have recombinant LH, where you have ampoules containing 75 units of LH, no FSH, no HCG. Then you have urinary derived HCG, human derived HCG, where you only have HCG, you have no FSH, no LH, and dosages of HCG ranging from 250 to 10,000 units per ampoule. Actually, most countries in the world, you can find ampoules containing 5 or 10,000 units of HCG. Other dosages are not very common. Fortunately, in Italy, we can still get ampoules with 250 units of HCG, which are very useful to do the kind of protocols that I will be showing you later on in my presentation. Then you have recombinant chorionic gonadotropin containing 250 micrograms of HCG. Now, if you are wondering how much in terms of native HCG that corresponds to, you see in the bottom the conversion factors. 1 micrograms of recombinant chorionic gonadotropin corresponds to roughly 25 to 30 units of HCG. So when you give 250 micrograms of recombinant HCG, it's like you're giving between 6,000 and 7,000 units of HCG. So a bit more than 5,000, a bit less than 10,000. HMG, I think it's not available any longer in most countries, and it's been replaced by highly purified HMG that contains all of the hormones, contains FSH, contains a bit of LH, but mostly contains HCG. That's a big difference between highly purified HMG and HMG. Because in HMG you had far more LH and less HCG, while in highly purified HMG, most of the LH activity is provided by HCG. Each ampoule of 75 units contains 75 units of FSH contains 9 to 12 units of HCG. And finally, you have recombinant FSH plus recombinant LH. Usually that is 150 units of FSH and 75 units of LH and no HCG at all. Again, if you're looking for conversion factors, 1 unit of HCG corresponds to between 5 and 8 units of LH. So you keep this number in mind, because you will have to do some multiplication later on in the presentation. Now, we all know, we studied in medical school, that basically, the ovary, the follicles, is regulated by the 2-cell Trigonotropin concept, which means that theca cells are stimulated by LH and produce androgens. Then androgens are, transferred into granulosa cells, where under the action of FSH, androgens are transformed into estrogens, and also FSH, of course, induces the development and proliferation of granulosa cells. Then, in the late follicular phase, mid to late follicular phase, but particularly in the late follicular phase, LH receptors begin to be expressed very vigorously by granulosa cells, and that is what makes the granulosa cells sensitive to LH activity and sensitive to the mid-cycle LH surge, which induces final follicle maturation and ovulation and final oocyte maturation. Now, let me summarize some queries that we're going through this evening. The first one is, does LH activity affect menstrual cycle dynamics? And the answer, of course, is yes, and that is particularly evident if you take the model of hypogonadotropic hypogonadism in women. And this is a patient we studied in the late 90s where she had profound hypogonadotropic hypogonadism. So we gave the patient highly purified FSH, and it took quite a while to achieve decent levels of estrogens and folliculogenesis, but eventually we gave HCG. Then we treated her again, and at that point we added to the same amount of FSH, we added low-dose HCG, 50 units per day. You remember this conversion, roughly 6. So 50 units of HCG means about 300 units of LH activity. And as you can see, the stimulation proceeded much faster. The patient achieved good levels of estrogens comparable to the menstrual cycle within 8 days. And the amount of FSH we ended up using was far reduced, almost a third, because in the first cycle we used 45 ampoules of highly purified FSH. In the second cycle, only 17. So adding LH activity in these patients is highly efficient. Now, then, we looked at a series of studies that we conducted between late 1990s and early 2000. And what is really, critical to understand of these studies is that these were fixed FSH dose studies, which means that the patients were receiving always the same amount of FSH. Because, when you start playing around with the FSH dose, of course, it's very difficult to tease out the specific effect of adding LH activity, adding anything else. So it's very important when you do this comparison that you do not change the variable of FSH dose. So when you do that, and regimens were extremely heterogeneous, including recombinant FSH, highly purified FSH, HMG, highly purified HMG, we always had the same effect, that the duration of treatment was significantly reduced. And also, when we looked at the amount of FSH dose that we used, also we were able to reduce the amount of FSH needed to achieve the same levels of folliculogenesis. So LH activity is very efficient in improving the outcome of your treatment. Second question is, what are the effects of LH activity on steroidogenesis? And one effect is very clear, and that is that adding LH activity will increase the levels of estrogens you achieve in your stimulation. Again, this is a fixed dose FSH study. But even more important, and we'll be discussing this later on, is that you have no impact whatsoever on progesterone secretion. Now, these are daily samples, so all of these patients were sampled daily, so it's a very robust assessment of steroid secretion. You see that androgens do not change, progesterone does not change, only estradiol goes up. And at the end, before you induce your ovulation, again, progesterone is not increased, while estrogen is higher in the HMG receiving patients. Third question is, does follicular phase LH activity administration stimulate excessive progesterone secretion, so-called premature follicle luteinization? Now, that is very important, and this, we all know it, but it was really very nicely outlined by our friend Dr. Bosch in Valencia. They looked back at almost 4,000 cycles of patients doing IVF, and they looked at serum progesterone on the day of HCG, and I'm sure you all read this paper. They noticed that, up to about 1.5 nanogram per milliliter, the results were quite good, but when levels went beyond that level, pregnancy rates started declining. So it's important, if you're doing your transfer in the same cycle, that you keep your progesterone under control. Why do you have this increment of progesterone during ovarian stimulation? I mean, the point I want to make is that everybody thought in the 90s, for instance, and also in the beginning of this century, that the increment of progesterone was linked to the LH activity you were giving to your patient. There's a study suggesting that HMG increases progesterone in the follicular phase more than recombinant FSH. That is really false, and I'll show you why. Again, let's go back to the two-cell Trigonotropin model. Okay, LH acts on TICA cells and can induce the formation of steroids up to the level of androgens. Of course, there is no aromatase in TICA cells, so androgens cannot be transformed into estrogens, and they can go two ways. They can either go in the peripheral circulation, that is what happens in polycystic ovary syndrome, or they can get into the granulosa cells to be transformed by the aromatase system, which is present in granulosa cells, into estrogens. Now, granulosa cells, of course, can induce steroidogenesis, but they really stop at the level of progesterone. So if you're stimulating too much granulosa cells, what happens is that, of course, some progesterone is good, that gets into TICA cells, but if you're pushing too much with your FSH, then your progesterone will go in the peripheral circulation and will increase your progesterone levels in the follicular phase. So really, it's an FSH-related phenomenon in ovarian stimulation. It's not an LH-related phenomenon. And we demonstrated that in 2002 when we looked at a group of patients treated with both FSH and LH activity, and we noticed that there was a direct relationship between the amount of FSH we were giving to the patient, so that the more FSH, the more progesterone, and while there was no relationship with LH activity administration. And keep in mind that each of these dots is not a single value. Each of these dots is area under the curve of the whole follicular phase. So again, a very robust assessment of steroid secretion. This was confirmed more recently in 2017 by this in vitro study of human granulosa cells, where it was clearly shown that if the more FSH you give, the more progesterone you end up stimulating from your granulosa cells. What are the effects of LH activity on follicular genesis? Again, very interesting. There's not much effect on the development of large and intermediate follicles. The significant impact is on small follicles. So that the more LH activity you give, the fewer small follicles you end up with at the end of your stimulation. And that is actually one of the reasons why HMG is used preferentially in intrauterine insemination, because you have fewer larger follicles, so the risk of multiple conception is kept under control. Before the introduction of GnRH agonist for triggering the final follicle and oocyte maturation in IVF in patients who had too much estrogen, too many follicles, and so on, that really deleted completely the risk of ovarian hyperstimulation. This was a nice approach to limit the risk of hyperstimulation, because by doing this, we were able to reduce the number of small follicles, which are closely correlated to the risk of hyperstimulation. Now, this is a bit less useful, but still very interesting concept to keep in mind. And again, this is a study from 2002 where we showed that the more FSH you give to patients and the more small preovulatory follicles below 10 millimeters you end up with. And, but on the other hand, the more LH activity you give and the fewer small follicles you end up with. So it's, everything really fits very nicely in this picture. And we brought this to fruition with another set of studies where we looked at what happens if you, in the second part of your stimulation after day 8, you reduce progressively the amount of FSH and you increase the amount of LH activity. And what happens is that you can, as you reduce the amount of FSH, if you supplement more LH activity in the form of low-dose HCG, you still support your large follicle, medium and large follicle development, and you don't need FSH at all in the last week if you give enough LH activity, which is, again, is a very interesting model. It could be, it hasn't been exploited as it deserved by pharmaceutical companies, because this would be a very nice way of reducing the cost of controlled ovarian stimulation, because in the second part of your stimulation, you use HCG, which is a very cheap hormone to produce, and you can save on recombinant FSH. So unfortunately, this hasn't been developed. I hope that things are going to change in the future, but still keep this concept in mind. And it's been shown by our group, it's been confirmed by our group, other groups such as the people from Brussels, and De Vrooy has published on the same protocol we had pioneered. Preovulatory follicles, as I told you, what happens if you only give LH activity in the form of low-dose HCG, which is group B, C, and D here. We see that small follicles decline, but there's no negative impact on large and intermediate follicles, as I told you before. So you can, in the last few days of your stimulation, you don't need FSH activity if you give low-dose HCG or any other form of LH activity. Finally, does LH activity administration affect oocyte, embryo quality, and IVF clinical outcome? There was some, the topic is, I think, is still controversial. There was some suggestions a few years ago. This is a meta-analysis showing that there might be a slight advantage in terms of birth rates by using HMG. It hasn't been confirmed in other studies. If we look at the largest study that was published a few years ago with the use of blastocyst transfer, what is interesting is that you can achieve the same levels of follicular genesis with less drug when you use recombinant FSH. And you end up also with a slightly but significant higher number of oocyte retrieved. But then fertilization rate, top quality embryos on day 3, blastocyst on day 5, ongoing pregnancy rates, and cumulative live birth rate are just the same. They're not different. They're not significantly different, suggesting that you may end up achieving the same clinical results with a bit less in terms of oocyte, suggesting that the overall quality of these oocytes and embryos is increased. So to summarize my presentation, LH activity can affect stimulation dynamics, treatment duration, dose of small follicle development, but the action can be masked by administration regimens. It will increase the serum and follicular fluid estrogen levels. It is not associated with excessive follicular phase progesterone secretion and will not cause the so-called premature follicle luteinization. The form and potency, particularly comparison between HCG and recombinant LH, are critical, but this is an area that hasn't been looked at carefully enough. It must be administered, LH activity must be administered to hypogonadotropic hypogonadism patient to achieve optimal estradiol secretion, follicular genesis, and may add oocyte quality. And the effect on ART outcome, implantation, pregnancy rates, and so on in normal gonadotropic patient is still controversial. Thank you very much.